Good morning, everyone. Want to just test out the audio, make sure that you can hear me okay. Coming through okay? Everybody could hear me? All right, we're good. All right, so welcome. This morning's discussion of Psyfeld will focus on the episode The Jimmy. So anybody have any ideas on where they would like to start with regard to their favorite character in terms of what they observed in the episode The Jimmy?
Can we talk about Jimmy first?
Sure.
So what I remember is like he keeps referring to himself in the third person every time he talks about himself, and that, and I also kind of felt like in terms of the way he spoke, he had a lot of like he used euphemisms and like also mentioned that he's new in town, doesn't know anybody, and I think like based on the way he was speaking, it sounded like maybe there was like a detachment, dissociation, like depersonalization component to what he's experiencing, and just the evidence of saying like I've been feeling like I'm new in town, like that kind of thing. It doesn't seem like he had very many other friends, which could be because he's new in town, but could maybe also indicate like social anxiety.
Yeah, so the observation that Jimmy's personality may in fact be the focus of clinical attention, specifically in how he appears to talk about himself in the third person. So I think quickly somebody may look at this as a personality trait and perhaps even a maladaptive personality trait, in as much as he verbalizes that he has few friends. Now, again, socially, he does inform us, he does provide the history that he is new. So that low hanging fruit can certainly be true and explain why Jimmy doesn't have any friends. And that's certainly something the clinician should inquire about. But the clinician perhaps wouldn't be surprised to understand that while that is true, where he previously moved from, he had that same social isolation. And might that reinforce the idea that this is a personality disorder that is clinically significant maladaptive personality traits? Once the clinician considers this, they are reminded in the DSM by the American Psychiatric Association that we really shouldn't entertain the idea of a personality disorder until we investigate some other things that are required to be evaluated for and ruled out. So, first and foremost, like any mental disorder, we have to make sure that substances are not playing a direct role in what we are observing. Um, Anybody here appreciate that the Seinfeld episode, The Jimmy, has anything to do with substance use disorder pertaining to this eponymous character? So I'm going to take the radio silence as a no, that we really don't see that that is Jimmy's behavior would be the direct physiologic effects of a substance. How about an underlying medical condition that might be central to the manifestation of your identified behavior in Jimmy? Any thoughts there? So again, radio silence, we're ruling out or we're ruling against a medical condition as being the etiology of Jimmy's behavior. With regard to personality disorder, the next step is to make sure that there's not a mental disorder that would have a personality change associated with it. And I think that's where your observation comes in. Might this be a dissociative disorder brought upon by the change? That is, thinking biopsychosocially, that from the social perspective, that his recent move has resulted in the diagnosis of a dissociative episode or dissociative disorder that has resulted in his speaking about himself in the third person. And I think that's the way your stream of thought as a clinician, that is your case formulation of what ails Jimmy, with the presumption that it is clinically significant. Of course, if it isn't, then the psychiatrist should not be rendering opinion about it, right? But for academic purposes, we'll assume that Jimmy's behavior is in fact clinically significant, so as to teach, at least introduce the concept of not only personality disorders and how to evaluate for them, but certainly the dissociative disorders as well. Couple things. In terms of symptom severity, distinct personality state that takes over one's conscious awareness versus amnesia versus milder signs of dissociation. If Jimmy, and I would suggest that Jimmy does not demonstrate a distinct personality state that takes over his conscious awareness, nor do I believe there are gaps in memory that cannot be attributed to normal forgetfulness. With those absent, we're dealing with milder forms of dissociation. And the single best answer, that is the most likely diagnosis, if this were in fact clinically significant, would be a dissociative condition, dissociative disorder, called depersonalization derealization disorder, where an individual has recurrent and clinically significant episodes of depersonalization and or derealization. And what might be going on here is that Jimmy may be experiencing depersonalization in that he just feels that some aspect of his awareness and his self is unreal in some way. The easiest example of that would be the out-of-body experience. I'm not suggesting that Jimmy is actually experiencing that, but certainly the way he relates to himself may suggest that. And I think that's where the clinician's attention now would be focused. All right, so that's Jimmy. And unless we actually work up for a dissociative or related mental disorder, we still would steer away from labeling Jimmy with a personality disorder such as the narcissistic personality disorder, which is where a lot of people go with the way Jimmy behaves. Any other thoughts about Jimmy? Any other characters you want to analyze and discuss today?
Can we talk about Kramer? I'm not sure if I would diagnose him with a mental disorder, but I don't know. With him going to the dentist and his obsession with the sneakers and other people thinking there is something with him, I don't know. I'm not really sure what to think of that.
So I think Kramer allows for a discussion on two levels. The first of which is the character, and only if you've followed Seinfeld over 9 seasons would you feel comfortable in contributing to the case discussion of what ails Cosmo Kramer. And certainly, if we're going to case formulate here, behavior that we see in this episode would support anything we derive by looking at this character over time, over the 9 seasons of Seinfeld. Kramer appears, in terms of big picture, to demonstrate behavior consistent of a cluster A personality disorder. We don't see any acute change from previous functioning. So over time, again, 9 years, almost a decade, we really are steered away from conditions like depressive disorders, bipolar and related disorders, anxiety disorders, and for the most part, even psychotic disorders. And because we don't see those changes, and his behavior is consistent over time, his may in fact be due, that is, his behavior that becomes clinically significant may in fact be due to a personality disorder. And when we think of the personality disorders, we look at the DSM categories and look at how the American Psychiatric Association has classified these conditions in 3 groups or clusters. And that first group, otherwise referred to as the cluster A personality disorders, contain 3 conditions that certainly define factors and traits that I think Kramer is quite consistent in demonstrating. He is odd, if not bizarre. He is, for the most part, socially isolated. And along those lines, he seems to live in his own inner world. And that fact is actually brought up on multiple occasions by his neighbor, Jerry. And along those lines, his would be consistent with the cluster A personality. And certainly in subsequent episodes through the semester, we'll identify further behavior that supports that. On the other hand, for this specific episode, in terms of the specific plot to the Jimmy, we also know that he is, if you will, misdiagnosed with having intellectual deficit disorder. So certainly this episode allows for the discussion of what was previously diagnosed and categorized on axis 2, the condition formerly known as mental retardation, right? Intellectual deficit disorder. A couple of important notes with regard to intellectual deficit disorder. Number one is that individuals with this condition have been tested through a standardized and validated IQ test to have an IQ that is 2 standard deviations below the mean. And on tests, this will come up. Students do need to know that average intelligence is about 100. So very easy number to remember. And a standard deviation is 15. That said, anybody scoring 2 standard deviations below that mean, that is below 70, is diagnosable, trying to choose my words very carefully, with intellectual deficit disorder. And the reason why this is critical is because most people stop there when it comes to making this diagnosis. What learners must also remember is that in addition to that diagnostic criterion, individuals must also demonstrate clinically significant deficits in adaptive functioning. All right? There are standard scales that measure adaptive functioning, their capacity to catch a bus, answer the phone correctly, tie their shoe, etc. Adaptive functioning must also be 2 standard deviations below the mean. And when it is, along with the intellectual deficit, you can then define or you can then diagnose intellectual deficit disorder. The American Psychiatric Association tried to move away from the politically incorrect term of mental retardation, and in doing so in 2013, they shot themselves in the foot because with this condition now renamed or relabeled intellectual deficit disorder, it's a misnomer. Intellectual deficit is only half the definition, which means that about 100% of the learners, medical students, graduate students alike, will not remember that second component, that is clinically significant deficits in adaptive functioning. And one final point with regard to how harmful this could be. There have been studies done that showed that when you take a group of people that do in fact rule in for being 2 standard deviations below the mean, about 80% will actually avoid being labeled with this condition upon adaptive functioning testing. So to only remember half the definition means that you are going to provide a false positive of 80%, which is actually very harmful. So be very careful. This is a misnomer, and intellectual deficit is only half the definition of intellectual deficit disorder. And I think that's what Kramer's character prompts in this particular episode. Any other thoughts on Kramer?
I was gonna say that the man that was with him in the taxi cab, I feel like when he was with Kramer, he kind of assumed that he was on the spectrum, and somewhere more like along autism.
Definitely could be. Definitely could be. I like Mel Torme's character here to be, I think, very consistent with the issue that I just described. You know, you have a character here that misinterprets Kramer's behavior and labels him. And that is very, very, very similar to a clinician that forgets about evaluating for adaptive behavior and then misdiagnoses their client, consumer, or patient with intellectual deficit disorder, believing that only intellectual deficit defines the condition. So again, there's a nice parallel here. And Larry David, the producer of Seinfeld, did this even before 2013 when the APA had that misstep and redefined this condition or relabeled it, making it much more difficult for correct diagnosis. Right? And yes, an autism spectrum disorder would be in the differential of intellectual deficit disorder in this particular case. Any other thoughts about, well, and just to keep on Kramer for one more point, and I think we can merge this with the point that I made previously with regard to Jimmy. What would be your differential with regard to Kramer's identified behavior, that behavior actually identified by Mel Torme as well? What's in your differential here? We said intellectual deficit disorder. We also said autism spectrum disorder, or ASD. What is his true diagnosis? Beyond the cluster A that I alluded to before, that really takes Kramer's character in greater perspective. Let's table that for a second. Paying to the specific episode and what you actually see in the behavior in the Jimmy. What is his diagnosis? Why does he behave the way he does?
It seems like Kramer, if I'm remembering correctly, is behaving this way for like very clear gain, like he wants to go to this dinner. And so would then the diagnosis be malingering?
I think that might be in the differential given the motivation you tapped into. But I think there's something even simpler to uncover here. I mean, what is it that Mel Torme identifies and literally talks to Kramer about? What is it that strikes Mel Torme? It's a speech, right? It's a speech. And what's the reason, or why is Kramer talking the way he's currently talking?
I think it's because when he goes to the dentist, he gets some kind of like numbing agent that makes him like slur and drool.
Yeah, absolutely. So, I mean, you can, from a non-psychiatric perspective, simply say this is a medication side effect. Novocaine has an intended effect to do that exact thing. However, once you leave the dentist office, you're often told about not eating for at least an hour because you're not going to be able to feel. Your hypoglossal nerve is not going to work and you're going to bite your tongue. That said, from a psychiatric perspective, if we can take a little bit of academic liberty, if we identify Kramer's behavior as hypothetically clinically significant, I really don't believe it is, but just for academic purposes, let's assume that it is, then I think we're back to this idea of a substance-induced mental disorder, right? This is all induced by a substance called Novocaine, right? So a little bit more metaphorically, but again, it does support the point. It does reemphasize this point that psychiatrists should not be diagnosing mental illness until they have definitively worked up and ruled out a substance-induced mental disorder. And in a way, that's exactly what's happening here, in as much as we identify Kramer's behavior as problematic and clinically significant, right? A substance-induced where that substance is Novocaine. So again, it ties back to this the same diagnosis that we discussed pertaining to a different character, that is Jimmy. We see it again here in Kramer. Any other characters that you want to discuss from our episode?
I was thinking of bringing back Jimmy, but talk more about George and Elaine.
Sure.
Because they both in the episode gained that feature of Jimmy to talk in third person. George did it with his boss. Elaine did it for a little bit at the dinner with I don't know if it was flattered with Jimmy or if it was something more. But is that like something? Or
That is something. Yep. What you're observing is actually a mental status exam finding. So again, you focused in on their speech, right? And speech, S, is part of the acronym ABC stamp licker, where the S in that acronym stands for speech, one domain or one component of a routine mental status exam. There are multiple deficits in speech. One is called echolalia. And echolalia is the observation that the individual you are testing, patient, client, consumer, simply repeats or begins to talk like the examiner talks, right? A similar observation or a similar mental status examination finding would be echopraxia, where they actually behave and copy the body motion and the body language of the examiner. So echolalia and echopraxia, speech and behavior, and by the way, behavior B is part of the acronym ABC stamp licker. Both of these observations are actually part of the routine mental status examination. So that's a good pickup. Now, a couple of points about this. Number one is that the routine mental status examination is itself a routine part of the neurological exam. And we've got to debunk this idea that we will only provide mental status assessment on people who are mentally ill. During the routine neurologic exam, we test for deep tendon reflexes, we test for cerebellar functioning, and we test for mental status. So it's a routine part of the neurological exam. And if you have not performed the MSC outside of your psychiatry clerkship as part of your standard physical examination, you're being negligent. So be very careful about this, right? So MSC is a routine part of the neurologic exam, which of course is a routine part of the routine physical examination we provide for all patients. Echolalia and echopraxia are similar or examples of mental status exam findings. Having said that, that's all they are. Like any exam finding, they may support a provisional diagnosis. So similarly, when you find someone to have a rash, or when you find someone to actually have an accelerated heartbeat, any exam finding, that in and of itself does not specify. It is not specific for any one diagnosis. It is just an exam finding that may support a diagnosis, and the mental status exam findings are the exact same thing. So the answer to the very common question, when somebody has or demonstrates echolalia or echopraxia, is that diagnostic of anything? And the easy answer is no, it never is, and it never should be. They're only clinical findings that might go to support one of the conditions in your differential diagnosis. Having said that, one condition that it supports that I do not believe is demonstrated in last night's Psyfeld episode is the condition of catatonia. Okay, the condition of catatonia. So both echolalia and echopraxia are DSM diagnostic criteria for a condition called catatonia. This is a condition, generally speaking, where individuals stop interacting with their environment. And most recently, in 2013, with the 5th edition of the DSM, has been moved into the psychotic disorders chapter. So, but again, I think to just belabor the point, to reemphasize my point, that does not mean Elaine is psychotic. All right, so it's a great example of how a clinical exam finding is not specific for any one diagnosis. In this case, a diagnosis of a psychotic disorder. Here's a quick question: can mental disorder be ruled out if it was triggered by a substance, but lasts even after the substance is out of the person's system? And the answer is that's tricky. Okay, I think on exams, the answer is that the mental disorder would actually then be supported once the clinician is reassured that the behavior identified cannot be attributed to the direct and physiologic effects of the substance because the individual has been abstinent from that substance. So that's why we always talk about provisional diagnoses when we first meet with patients, and that only after a close observation over a period of time might those diagnoses be supported versus for lack of a better word, debunked. So keep things provisional upon first meeting people, upon first meeting patients, and allow for the introduction of new information to have an opportunity for the clinician to adapt and change their diagnoses, and certainly the hierarchy of their differential diagnoses. And if an individual is free from substances, if they are abstinent, and they continue to demonstrate the identified symptoms, then that strongly supports that you're dealing with an established mental disorder and that the substance did not play a central role in the manifestation of that disorder. It certainly could contribute to it, certainly could act as a precipitant, but the behavior would not appear to be the direct and physiologic effect of that substance. Good point. All right, any other characters? Okay, before we stop, I just wanted to make one observation. That, of course, well, not of course, that is focused on the dentist himself and his interaction with Jerry in the office. Very quickly, can somebody identify what they saw when Jerry goes to the dentist?
Jerry noticed that there were like weird magazines at first, and he admitted that he looked and whatever, and then when he was waking up from coming off of the Novocaine, he realized that the nurse practitioner and the dentist looked like they were like kind of putting their clothes back on. But I don't think he ever really went into it after that. He kind of just like said, oh, like that was weird, but in reality that's like a really big thing to see after the dentist.
Yep. So again, I think that observation is right on. I think it's exactly what everybody else observed with regard to watching the Jimmy, and it just serves to introduce another topic that we're going to now pick up and segue to for our noon conversation over Periscope when we discuss the Disney cartoon Cars and what might be going on. Okay, so I'm going to leave it out there as a teaser. For those of you who are interested, join us on Periscope at noon. We will tweet the actual start time, and we will actually focus on this film as a case study of a substance-induced disorder. That substance, again, to be announced, but certainly there is a link to what happens to Jerry in the Jimmy. So until then, I wish you a good morning. I will be starting morning rounds at about 9:30 today for those of you who are in the hospital, and we will see everybody back at noon for our discussion of Disney's Cars. Thank you.
Thank you.